Okay, so let's talk briefly about dynamic cardiology and the National Registry Scaletation of Dynamic Cardiology. A little different than static. With dynamic, you're actually going to be expected to operate the cardiac monitor as part of your evaluation. Um, so again, there's several different cardiac monitors out there. Hopefully by this point you practiced with all the different ones. You practice with the Zoll, with the Philips, with the LifePak, and are able to do things like defibrillate, like pace, like synchronized cardiovert, um, like adjust the screen, run a 12 lead, adjust the leads you're looking at, all those kind of things you need to be able to do on the cardiac monitor for the dynamic station. Um, with the dynamic cardiology, you can expect to be presented with a patient who is going to go through some rhythm changes. Um, they are going to decompensate at some point. They are going to require you to run the cardiac monitor, like we just said, and do some of those various skills with the cardiac monitor. The uh, fact that the patient goes through rhythm changes and or decompensates is not necessarily a reflection on you and the skills or the treatments that you provide or don't provide, but rather it's part of the scenario. So don't be stressed out when the patient goes into a rest or you don't get ROSC or things like that. It's not necessarily a reflection of you. Just go through the algorithms, work the patient, and you'll be fine here in this station. Um, so also remember that we can't ignore things like good BLS and good ABC management with these types of patients in this station. We always want to make sure we are doing good basic care and managing that appropriately. There will be a mannequin in the room. You can choose to use the mannequin if you like, as far as putting the pads on the mannequin, if that visually helps you to stay on task and to stay on your algorithm, that's fine. You don't have to necessarily address the mannequin, but you do have to be the one who runs the cardiac monitor. It may be an actual monitor, it may be an iSimulate unit. That's not really something that we know until the day of the test. So, but we do need to make sure we're voiced treating effective things. We need to voice things like putting the defib pads on the patient. We need to make sure we're verbalizing PPE. We need to make sure that we are verbalizing the starting and stopping of CPR, even though it's not actually going to be happening. There won't be an actual physical partner in the room with you here. It'll just be you and the evaluator. So you'll have to verbalize telling your partners to give vital signs or to check sugars or to start or stop CPR. So that being said, let's get into it. For the sake of this demonstration, we'll say this is a 65-year-old male with chest pain. So we arrive on scene. Of course, the scene is safe. We take our appropriate PPE. We check patient responsiveness. The patient is alert. Verbalize checking our ABCs. So we'll say the airway is patent. Breathing a little bit fast, but no obvious difficulty in breathing. And we check in circulation. Checking skin color condition. The patient is pale, cool, diaphoretic, and the patient has a rapid and weak radial pulse. So at this point, since it's a dynamic cardiology station, we should probably be dealing with the cardiac monitor pretty quickly. So we would go ahead and turn on our cardiac monitor and put a 4-lead on the patient and see what we get from this. Alright, so immediately upon turning this on, we see that we have a tachycardia. Alright, this is a wide complex tachycardia. It's regular, so we'd want to identify this rhythm as ventricular tachycardia, VTach with a pulse. Okay, so with VTach with a pulse, we do a few different things depending on whether the patient is stable or unstable, so we need to determine that pretty quickly. We can do things like attaching pulse oximetry and seeing what that tells us. We can do things like checking your blood pressure, seeing what kind of information that gives us. All these signs should be pointing you down the road that this is a unstable patient. He's got chest pain already, so that right there is unstable. He's on hypoxia count, 92% saturation. And once his blood pressure cycles, we see he's hypotensive as well. So all these things should be telling us that we need to apply some electricity to this patient. So we put the pads on, we go ahead and hit our sync button, make sure that our monitor is captured. We can choose our energy. We'll start at 100 for a wide complex regular tachycardia. So it's synced, charge everything up, patient and deliver air energy. Remember though, you have to hold down. There we go. Alright, so our wide complex tachycardia persists. There's no change in our patient presentation. We're going to go up a step here. Charge again. Alright, clear the patient. Deliver our energy. And we can see we've had a rhythm change. Okay, we identified this rhythm as VFib. We would immediately start CPR, and because this is witness VFib, we're going to dial up our energy even more and give a defibrillation dose. Pause CPR, clear the patient, defibrillate, right back on CPR. Make sure we're verbalizing that we're going right back to CPR immediately after defibrillation. So, VFib, what do? Well, we want to start an IV or an IO. Alright? If we haven't already done so, you might have chosen to start an IV back in the previous stage when he was unstable, VTAC, and that would have been acceptable and appropriate. So, we have a patient in VFib, we're doing CPR, we have another partner there, we could instruct them to do ventilations. We want to be doing that at a 30:2 ratio. And if the IV is successful, the preceptor will let you know the IV is successful. You would go ahead and give your first drug, which is going to be a milligram of 1 to 10 epi, IV push. So that's on board. CPR is going on. The preceptor is going to tell you that 2 minutes is up. I'm going to pause CPR to check a rhythm. VFib persists. Resume CPR while we charge the monitor. Clear the patient. Defibrillate. Back on CPR. Again, got to make sure you're saying back on CPR after you defibrillate. You don't want to have any lag time. Alright, so we're back on CPR. At this point, we can consider things like maybe an advanced airway, if you wanted to put in an iGel or a King, or if you wanted to innovate. And with that being said also, you could go ahead and say you wanted to monitor some end-tidal capnography if you were able to innovate or put an advanced airway in. Alright, that'd be a great idea because we know that end-tidal CO2 of 10 to 20 would indicate that we're doing effective compressions. Alright, so you can change your screen to be able to view these kind of things. We also want to talk about during this time that the next drug we want to give is amiodarone. And again, our first dose of amiodarone is 300 milligrams, so we go ahead and push that in. Alright. So the preceptor will tell you that 2 minutes is up, and we want to pause for rhythm check. VFib persists, so we're going to go ahead and charge the monitor again. Clear the patient, defibrillate, back on CPR. We're going to need to go back to epinephrine now because the time has gone on long enough, so back to a milligram of epinephrine, 1 to 10,000 IV push. The preceptor will tell you that 2 minutes is up. We want to clear the patient, check for a rhythm. VFib persists, so we want to charge again. Clear the patient, defibrillate, back on compressions. Okay, so we're going to do compressions for another 2 minutes. Disregard the fact that the rhythm changed. Don't get sucked into wanting to check for a pulse and things. We're going to defibrillate and 2 minutes of CPR immediately. So the preceptor will tell you that 2 minutes is up. Pause for check the rhythm and the pulse. There's no pulse with this rhythm, so you're going to identify this as PEA. Alright, now we're working the PEA algorithm. The PEA algorithm is, remember, CPR and epinephrine. So if, depending on where you are in your cycle, if it's appropriate to give epinephrine at this point, you can. If you just gave it a minute ago in the VFib side, you can, verbalize that. But at some point, you need to make sure you give an epinephrine. Also, at this point, we need to start thinking about H's and T's. The preceptor may ask you to say what are the H's and T's. So make sure you don't say something and then you're not able to follow up. So you guys should know the H's and T's though by this point. So you can think about things like hypoxia, which you should be correcting with a bag mask and 100% O2. You can think things like hypoglycemia, which is not really in there anymore, but we can always always still check it. Hyperkalemia, we can think about that. We can think about fixing the acidosis, the hydrogen ions. Hypovolemia, we can give fluid boluses. Hypothermia, thinking about toxins and tamponades and tension pneumos and thrombosis. And so just remember that the preceptor, if you say H's and T's, they may actually ask you to tell them what the H's and T's are. So 2 minutes is up. We'll pause for a rhythm check. There is no pulse with this rhythm, so we're still in PEA. We would go back on CPR and give another milligram of epi, 1 to 10. The preceptor again will tell you that 2 minutes has passed, and so stop and do another rhythm check. There's, there may or may not be a pulse. It just depends on your time and where you're at with your treatments. But at some point, the rhythm's going to change again, and depending on where you are with your cycle of treatment, you can here we go. So we can see now the rhythm's changed again, and that whenever it's appropriate, after your 2 minute cycle of CPR, you'd stop for a rhythm and pulse check, and you'd say that we do have a pulse with this rhythm, so we could identify it as ROSC, and we want to be doing the appropriate ROSC care. So things like simply getting 12 lead, things like fluid boluses, managing oxygenation to at least 94% or greater, right? So let's say we'll acquire a 12 lead here. We also at this point want to recycle our blood pressure. So we can do this 12 lead here, and this one doesn't look too bad. So we can rule out some type of a STEMI with this particular patient. See our end-tidal CO2 is a little bit high. We want to make sure we're managing that to appropriately 35 to 45 is our goal there. Our O2 is currently at 100%, so we want to make sure we're targeting that to at least 94% or greater, and then transporting to the appropriate facility. And that would be the end of your dynamic cardiology scenario. So as long as you were able to effectively manage those 4 rhythms, you should be okay. I'll put up some other videos with some different scenarios, some symptomatic bradycardias, some tachycardias, so we can make sure you can go through those algorithms correctly. But as you watch these videos, just make sure you are just verbalizing to yourself out loud or writing down, making notes of how you're going to treat each one of these scenarios. And the big thing with the dynamic cardiology, aside from knowing the appropriate care, knowing the appropriate energy to deliver, is never letting there be gaps in CPR while that's going on. You always have to make sure you're verbalizing. We're pausing for a rhythm check. The rhythm is X. We're back on compressions while we're charging the monitor. Once we clear the patient to defibrillate, once the defibrillation has been delivered, we're back on CPR immediately. All right, so we can't ever have any gaps where we stop CPR, because remember, just like documentation, if you don't document, it doesn't happen. In this station, if you don't say it out loud, some of these things don't happen. So if you're not able to physically manipulate the cardiac monitor to do something, if it's something that we're verbalizing like CPR, you have to make sure that you are verbalizing the starting and the stopping of CPR as appropriate. All right, if you guys have any questions about this, shoot me an email and we'll address it.